Hi, and thank you very much for joining us today. I'm Mohamad Bashir for the CTSNet Aortic Portal. We are at the EACTS 2016 in Barcelona, and I planned for you a nice topic, which is type A aortic dissection, optimal strategy, surgery, and outcome. We've heard a lot about aortic dissection during this meeting. In a nutshell, there are many controversies that are regarding the risk identification, strategy, correct surgical intervention in the context of thoracic aortic dissection. And for this reason, I've invited for this particular session top experts on this topic. From my left-hand side here, I have Ali Koinzad from Cedars-Sinai Heart Institute in Los Angeles in the US. Also, I have Dr. Joe Bavaria from the Hospital of University of Pennsylvania in the US. On my right-hand side here, I have the president of the AATS, Dr. Thor Sundt from Mass General in Boston. Next to him, I have Professor Heinz Jacob from Essen in Germany, and next to him I have Dr. or Professor Martin Grebenwager from Hospital Heidsieck, Vienna in Austria. Thank you very much for joining me today.
Thank you.
Tor, the question is to you as a starter.
All right.
Size, we've all read in the literature, size is not everything.
Yeah.
And in the setting, especially of an ascending aortic aneurysm, to prevent aortic dissection, what do you think are the other risks, entities that we need to look at in this setting? What are the risks that we need to look at in type A aortic dissection?
So I think that's a great question, and more than, I think the point is we don't know what else to look at. Here's what we know. We know that as aortic diameter goes up, the risk of dissection increases, but we also know that many dissections happen in small aortas.
Yeah.
So it's a little bit of a misdirection play. We have gone after the issue of diameter and been more and more aggressive about replacing smaller and smaller aortas. I have felt, without substantial evidence, that they're at significantly increased risk of dissection. Mm-hmm. There have to be other parameters. There's an old joke about the individual that drops their keys on a dark street, and they're looking underneath a light post. Someone comes by to help them find their keys, and they say, "How can I help you? Where'd you drop your keys?" And they say, "Well, I dropped them up the street, but the light's better here." And we're sort of doing that with aortas, I think. We're looking at the wrong parameters, and I think a great area of opportunity for research is to find out how else can we evaluate risk of dissection. Aortic diameter is not a good way to evaluate the risk of dissection. We've got to find other parameters. Is it history of hypertension? Is it material properties of the aorta that are identified by advanced imaging properties? What other things can we look at?
That's great.
I think if I were a young surgeon looking for a career opportunity in research, it would be that, looking at parameters other than diameter to help guide us for prophylactic resection for patients to prevent dissection.
Thanks, Thor. That's a beautiful wrap-up of where we are at in terms of size. Joe, when should I replace the root in aortic dissection?
When?
When should I replace it? Is there a place for valve sparing procedure in this setting? So two questions. One, when do I replace the root? And two, would you do a valve sparing?
When do you replace the root in a dissection case?
Yeah.
I think you should replace the root in a dissection case for sure in patients who have a dilated root that is especially dilated pre-dissection. So if you can look at the root, you see that it's dilated. It has that look and it has that feel and tissue turgor that is a dilated root to begin with. You should replace the root in all Marfan's patients. You should probably replace the root in most bicuspid patients who dissect, although that's a little bit more controversial. We just published a paper showing that we had exactly the same results in bicuspid valve repairs versus regular operations.
Even if the dissection is not involving the aortic valve in a bicuspid setting?
Yeah, so this is about the root now. So the more nuanced answer to your question is also that you should replace the root if the tear goes down. That's an absolute indication. The tear goes down into the root. In other words, if the tear is below the sinotubular junction. Where the great controversy is in whether you should replace the root if it's simply dissected into the root. And there's a balance there. In my opinion, this is the major tension that every surgeon undergoes who knows a little bit about aortic surgery and dissection when they're actually doing the operation, which is, we all know that the single best operation for 75% of all dissection cases who had normal aortic valves, 3 seconds before they dissected, and pretty normal roots, that the best operation for those patients is a valve sparing operation.
Okay.
But when should you be doing valve sparing operations in all dissections, especially when you have to do a lot of other stuff?
Yeah.
Especially when they're sick for other reasons, and especially since, most importantly, that most of the morbidity long-term is not at the root. Most of the morbidity long-term is at the distal aorta. So, we also know what maybe the best operation is distally. Maybe we'll get into that.
Yeah.
But if you're going to think of this holy grail operation, which is a really good distal operation and a valve sparing operation, that's not reasonable.
Yeah.
Okay. So we have to make compromises. So I think there are clear indications for root replacement. We shouldn't really go past those, and we should just use regular aortic reparative concepts for dissections, which is valve resuspension, kind of robust aortic root repair, and then get out of there and do the rest of the operation. That's for 75% of the patients. That's what I would do.
All right.
Can I ask Joe a question?
Sure, go ahead.
So what about the age of the patient? So imagine the patient's, the dissection goes into the root, but not the tear. They have no known connective tissue disorder, but they're very young. So you're suspicious that they have, so let's imagine it's a 40-year-old with an acute dissection, no explanation for the dissection.
They should get a valve sparing operation.
They've got no known connective tissue disorder, but they're awfully young.
Yeah, and they've got a dissection of the root.
Yeah.
That should be probably a David 5. I would do a David 5 in that case. Yeah. For 40. But you got to remember that if they have a malperfusion or some sort of arch tear, and you got to do a big arch operation, then you're talking about a 300-minute to 350-minute bypass run, and that, even for a 40-year-old, is an issue.
And we're going to come to the malperfusion in a second. Ali, you want to say something?
May I comment on that? My contrarian view about doing a David type sort of surgery and a type A dissection is that it's a complex operation. The goal of operation initially is to make the patient survive the initial insult. So if you have a group of surgeons who are not very experienced in aortic surgery, and suddenly you're requesting in a certain patient population to offer a David, the morbidity, mortality of that patient goes high. If you have a significant AI and patient need recross clamp, I'm not sure we're doing that patient a service. Now, if there's a regionalization of the aortic referral, and such as in Pennsylvania at UPenn, and if there is a group of surgeons at that institution that does high volume, that may be a more reasonable option and a very acceptable option to offer a type, David operation. I think those are easy.
Yeah, but even at our place,
easy David operations.
Even at our place, we only do 8 to 10% David procedures in type A dissections. Very specific cases like the one he just talked about.
Yeah. Well, I'm going to stay with you, Ali, because I'm just going to shift the question to you. Thoracic endovascular repair. You've written a nice paper recently, which I've seen out there. Thoracic endovascular repair for acute type A aortic dissection operative techniques. What's the pathology substrate you are working on, or you work on, or you tend to see in your field, and what are the indications want to go endovascular? So I'm going to ask you this. I'm going to ask you then, Heinz, about the same comment to see what you're going to say different to what Ali. Ali?
Well, first of all, the gold standard is open repair.
Okay.
So I would say 99% of dissections and aortic roots and ascendings at our institution are done open repair, the standard way. So I've been quoted and been asked to give a talk on ascending dissections and stent grafting. Well, my practice is 85% open repair. So I just want to make sure I clarify that first.
Okay, good.
So having said that, there are a subset of patients who are octogenarians, sometimes nanogenarians. They have previous aortic valve replacement and have a de novo dissection. They may have additional comorbidities such as prohibitive lung issues. They may have a dissection or pseudoaneurysm abutting the sternum. Those are a subset of patients who are high risk for open repair. Yeah. Even in experienced hands, I would argue. And those patients, I think the endovascular repair, it's a reasonable option. And it might be just a bridge. So it might be a bridge, allow us to get the patient over an acute event, which is a type A dissection. And I see it very similarities with type B dissection. If you have a complicated type B dissection, stent graft could be a bridge to an ultimate open operation in 3 months. Okay. And type A dissection could be as well, or it could be destination therapy for some elderly patients with cardiovascular conditions that are not substrate for successful open operations. All of us can get a patient who is very sick through the operation. The question is, what's the longevity, what's the quality of life, and how is that patient going to come back to normal lifestyle that patients experienced before surgery? Those things have to be accepted.
This is a question remains to be answered. Heinz, thoracic endovascular repair of acute type A dissection, operative techniques. Do you agree with that? Do you tend to do that? Or do you just agree with what Ali was mentioning?
Yeah, we always look at the whole package of the patient. So we had, I think, two cases of endovascular repair, but finally we lost all those patients. The first one was after implantation of a core valve. So we put in a stent graft in the ascending aorta, and the other one was a left main dissection. We put in a core valve and additional prosthesis, but none of those patients made it. So I think this is still somewhat premature. We are working on some stuff to maybe create a kind of conduit put in transapically, but it's not that easy to achieve. So open repair, even in the elderly, is still the option number one.
That's very good that you clarified this, Heinz, and very good that you clarified this, because people might take the concept from the papers that we read in the literature that actually you are after endovascular repair, even in the setting of acute aortic dissection. Martin,
yes.
Do you agree with the term tear-oriented surgery? This is like now it's going out, you can see it on different panels, tear-oriented surgery for acute dissection.
Yes, of course, you have to be tear-oriented, there's no question about, but you have to do more than only resect the tear, because I receive more and more referrals in Austria where the ascending aorta, the tear was resected with the initial operation, so it's an ascending replacement of maybe 2 to 3 centimeters.
Oh, yeah.
So I can assure you, 3 to 5 years later, the patient comes with a huge chronic dissection of the distal ascending arch and descending aorta. And then you have to operate this patient, which is not so easy. So I think you have to tailor for each patient an individual track, what to do. Frozen elephant trunk, it's a very, to do more, to replace the arch and stand the true luminal descending aorta. But of course, it's not the way to go for every patient. So you have to take into account the age of the patient, where are the tears, and we in our institution we have now the politics. If it's a very old patient, we go of course open distal anastomosis, hemiarch replacement, and then to make with the root what we have to do, supra above the sinotubular junction, or to replace the root. If the patient is younger and we have maybe an entry tear within the arch or in the distal to the left subclavian, we would be more aggressive. So we would go for a frozen elephant trunk procedure. Because a frozen elephant trunk is not only that he makes the duration of the operation longer, it helps you to make a secure, a safe distal anastomosis. It expands the true lumen, and then it makes it easier, because always with the discussion, should we limit to the operation to reduce the risk, or should we operate more, but with the price of a higher risk? And in experienced centers who are used to use this elephant trunk, in my opinion, we have not to pay the price of a higher risk anymore, only by inserting a stent graft.
Great.
So I cannot recommend in general to use for every type A dissection a frozen elephant trunk. This is by far too much. If the patient is 85 years of age, I would never go for a frozen elephant trunk. Instead, maybe even in an old patient, it helps me bringing that patient alive out of the OR. And because it's good to have this frozen elephant trunk in your armamentarium.
We're gonna touch base on the frozen elephant trunk in a minute, but I just want to grab your thoughts on Thor, on the we were talking off air on aortic arch in the setting of aortic dissection. Would you just replace the arch for everybody, or what are the indications for arch replacement in a setting of acute aortic dissection?
So I would in our institution, it's uncommon to do a total arch replacement in the setting of an acute dissection. I like the idea of doing a proximal arch that then sets you up to be able to do stent grafting, so a partial arch. The standard operation is still a hemi-arch, and in the US at least, most surgeons that operate on dissections don't operate on a lot of dissections each year. And so I think it's still true, and this has been brought out several times in this meeting. It's fine to talk about these complex procedures, but you don't want to convey the message to every surgeon every time. Ali touched on this, that this is the complex operation you need to do for a dissection. Some would argue that those patients that are coming back to you with a short segment, coming back for a redo operation, are a success because they're alive to come back to you for a redo operation.
Yes, you can see it also from this side.
Yeah. Joe, what do you think? Do you have any comments on what Tor has just been mentioned? Do you agree with this approach?
I have a historical perspective that I think is, 20 years ago, everybody was doing ascending aortic clamp type A dissection repairs. And now most everybody, not everybody, but most everybody is doing at least an open distal anastomosis or hemiarch operation. It's become the standard, pretty much the standard of care. It's been taught, and the trainees are all doing it. And the old guys, that didn't know how to do that, were just doing clamped type A dissection repairs. They're not around anymore. So, in my personal opinion, we're going to go to the next phase. The next phase, to me, is either going to be kind of like Tor was just talking about, which is what we do routinely now, which is a zone 2 arch, what we call a zone 2 arch. And the zone 2 arch sets you up for anything in the future. It takes care of the arch disease. You could put a standard stent graft in with a subclavian carotid anastom bypass. You could put in the new single branched arch branch vessel TVARs, which are coming as we speak, to the point where we've actually changed our operation for type A aortic dissection to accommodate the availability of these new grafts. I mean, it's pretty amazing. And then the third thing, of course, is to do a frozen elephant trunk. But I think that slowly but surely, at the very minimum, a zone 1, zone 2 arch is going to be done on everybody, and should be done on everybody if they have any training. And then the question will be when to do it frozen or not. So the hemi-arch will be replaced by a kind of a mid-arch operation that it allows you to have the option of a TVAR downstream aortic solution. That's my opinion.
Great, thanks, Joe. Heinz, Martin mentioned something about the frozen elephant trunk. Frozen elephant trunk has a wide array of use and utilization, but in the setting of acute aortic dissection, Martin touched base on extending the circulatory arrest time, extending the cardiopulmonary bypass time, and as Torres just mentioned to us now, is get the patient out alive, doing what's in the patient interest. What's your take on frozen elephant trunk in the setting of acute dissection, knowing that Essen is a group that innovated a lot in frozen elephant trunk?
Well, 60% of my type A's are getting a frozen elephant trunk. But first of all, we have to differentiate between type 1 and type 2. And we extended the definition of type 2 to the end of the arch. And if there the dissection stops, we do ascending and arch replacement, that's it. So no indication for frozen elephant trunk. So there's only indication when we are opening up the arch, and there are additional tears in the distal arch around the subclavian artery or in the proximal descending aorta, and we do angioscopy in all patients and we see it exactly. And I think that we can justify doing it because we are doing the zone 2 approach for the last 5 years, and the rapid lower body perfusion using a balloon cannula after the distal anastomosis in zone 2. So zone 2 anastomosis is very easy. Every surgeon can do it. And plugging in a balloon-tipped cannula, we are now down at 35 minutes of visceral ischemia and less than 60 minutes of cerebral antegrade perfusion. So I think this is a complete different story. We are now at the same risk for this operation in contrast to the just proximal or hemi-arch replacement.
Great, Heinz, thanks very much for that. Tor, we got to talk about optimal brain protection method. We're writing this AATS guidelines with Tony Estrella on how do we protect the brain during the setting of aneurysm repair. What's the best or optimal brain protection method that you would use, and what temperature you would go down to?
Temperature of the perfusate to the brain or the perfusate to the body?
Perfusate to the body.
So the best brain protection is to never interrupt blood flow.
Okay.
Has to be. I mean, that goes without saying, right?
Yeah.
So anything short of that is what are you getting away with? No, right? So you make modifications to see how long you can cut off the blood flow. So antegrade cerebral perfusion is the best way to protect the brain because it's not interrupting blood flow. I think that's a truism. The question of how cold the brain should be is even interesting. There's some controversy about what the perfusate temperature should be for the brain.
Yeah.
I still cool for 30 to 45 minutes, and that's usually 18 to 22 degrees, something like that in the body. And I just feel most comfortable with that. I don't think that it increases bleeding, and it's usually by the time you've done the work that needs to be done, I don't think it prolongs the case very much. But that's not the way probably that Joe does it or Ollie does it. He'd probably go warmer. But I worry about protecting the rest of the body.
All right, that's good. Ali, you want to make comments on?
Well, I have sort of changed over the last 5 years to become a more moderate hypothermia.
Yeah.
So I'm operate typically anywhere between 24 and 26. With the aneurysms are typically about 26. With dissection, I go to 24. I've used transcranial Doppler over the last 8 years, actually. It started with TVAR experience, and now also for dissections. It helps you get an idea of flow velocities and pulsatility index in patients who, before the procedure, and offer the same amount, same flow rate with an antegrade cannula as well. So it gives me some baseline parameter, because just going by a flow rate of 10 cc per kg, typically either it can overestimate or underestimate, and each of them have detrimental effect on the brain. So I think the blood to the brain has to be cold. We're about 22 degrees on that, but the velocities, it can be changed. Also unilaterality or bilateral ventricular perfusion, those are important aspects. And if I have an extended operation more than a hemiarch, I usually have bilateral cannulas inside the carotids. So.
Okay.
Now dissection can be a little bit tricky, because if you have a dissection flap going inside the carotids, that can complicate the situation.
That's true.
And in those cases, I always have, that's one of the few cases that I do axillary cannulation.
Yeah.
Otherwise, I like the central cannulation. I know Joe has been described that before as well. And I think that makes the entry and the advancement in the surgery much faster. It cuts down about half an hour on procedure time.
Yeah, we have a massive change on some of this over the last 5 years. We're doing almost routine central cannulation now. We're getting away from axillary cannulation for a number of reasons. The first one is I'm not so sure it's completely benign when you have a nominate artery and even left carotid artery dissection.
Yeah.
Also, people don't like it. We've had small problems with nerve injuries, et cetera, et cetera. So we've gotten away from that, and the only time we use axillary cannulation now for type A dissections is the redo. We still do the redos, but we do 250 consecutive central cannulations for the most part.
Yeah.
And we use antegrade cerebral perfusion. We'll cut the aorta out, start the cannulas into the innominate and left carotid artery, making sure that we have the issues covered with dissection into those vessels if necessary. And we use NIRS on everybody, make sure the NIRS are okay.
Yeah.
And I use a left common carotid artery pressure measurement during the case, so it's really very, very well monitored. So that's kind of our approach now. And we're doing it. Anybody who has life expectancy over 10 to 15 years gets a zone 2 arch.
Yeah.
It's kind of we've changed our protocol. And I actually go to 20 to 22 degrees as well. Still go pretty cold.
Yeah, I think that I'm very much interested in what you both think, but as I've listened to people talk about going to moderate hypothermia, it sounds more like what I called profound hypothermia. I mean, it's cooling for an hour plus.
That's
I've never done that. Yeah. It's not the way Kachukas taught me to do things. He used to say always cool for at least half an hour. So it's sort of a, to me, it's 30 to 45 minutes, and actually it may not be that different from what some are calling moderate.
Well,
I don't know. What
could you
what do you
actually, Tor, if I remember, one of his studies actually reviewed this circle rest situation, and at 50 minutes cooling, that's where the majority of brain waves will be isoelectric. So I remember that was one of his words that,
Joe's
oh my God.
significant work in that.
Oh, President, I'm sorry about that.
We will edit that.
Thank you. So I think that's a lesson that I remember. If I want to do all the way deep hyperthermic, and I don't have any information about regional oxygen saturation, 50 minutes might go away. But those are cases that typically are more complicated redo. It's for sure total arch. For regular hemiarch, I rarely have to have a circle rest time that is more than 15 to 25 minutes. That's bottom line.
Yeah. I want to put the attention to one point. It depends where you are measuring, because if you're really measuring core temperature, is it a rectal temperature or visceral bladder temperature?
Yeah.
And a lot of centers are measuring the nasopharyngeal temperature via the, or a tympanic temperature in the ear. And so this is much lower than really the core temperature.
Yes.
So if I say the real, I have a fly here.
Brain temperature, this is what I do. Brain temperature is arterial inflow temperature. Whatever the arterial inflow temperature is, that's what the actual brain is, because the brain gets so much blood flow. So you can actually figure out what the brain is. If you ask your perfusionist, what's the arterial inflow temperature? That's what the brain temperature is.
Right. This issue about moderate and profound hypothermia is not about the brain. It's about the rest of the body.
And one additional aspect is there exists an autoregulation of the brain. And some people are arguing if you are very cold and you're perfusing the brain with below 20 degrees, this is not so good because you receive a vasoconstriction of the arteries. So a warmer, moderate, not warm, 26 degrees is for the perfusion of the brain better than to go too far down. But even in my unit, I need 30 to 40 minutes till I reach 27 degrees. So, but we are measuring the bladder temperature, the rectal temperature. If I would measure the nasopharyngeal temperature, it would be 22. It's mostly 5 degrees difference.
There's always a controversy when it comes to...
in every paper you have to read it exactly. They are measuring on different sides.
That's why if you really had EEG, that would be the best way. That would be the best way.
Cooling to a rectal temperature of 18 degrees. Oh my God, I can't.
I mean, that's crazy.
You have to warm up them for hours.
I don't even use rectal temperature anymore. I tell them not to put them in.
Right.
Well, you see, we are using the 28 degrees of core temperature, bladder temperature, and when we reach this temperature, then we go to the arch procedure and perfuse the brain with 22 degrees. So for those 35 minutes, we do it with 22, and after starting up the visceral reperfusion, we slowly go up.
So I think that's a very important point.
Yeah.
So when we have done our cerebral perfusion after, let's say, 60 minutes, the core temperature might have been dropped from 28 to 27 or something like that. And this, in summary, will shorten up our circulatory time. And this was found in our study, wrapping up all our cases, that one risk factor was to have an extracorporeal time beyond 250 minutes. So we have to cut down to this.
Great.
Do you measure EEG?
No, we have NIRS. That's it.
NIRS,
Let's move on.
Okay.
Malperfusion. I want to touch base on malperfusion in this setting, in type A aortic dissection. Ali, what would you do?
So malperfusion is a grave condition that complicates the management of a type A dissection.
Yeah.
And in our institution, we have initially addressed the malperfusion itself, meaning if the patient has an intestinal or ischemia to the extremity that has been relieved before we proceed with a prompt open repair. I think in our hands, this has shown to improve outcomes because on occasion, and not common, but on less common occasions, you can continue to have malperfusion if you have an anatomic malperfusion to the intestine. So any resection of a septum and distal arch and reperfusion of false and true lumen will not relieve an anatomic malperfusion to the branch vessels, including SMA and celiac, that are very sensitive for, in terms of patient survival. So in those cases, we go in, we put a stent graft in, if need to be, we stent in the branches, or we do an open bypass if need to be. There's been 1 or 2 patients we've had to do that. But after that, once that's relieved, we confirm that malperfusion is relieved, we proceed with the type A repair.
Okay, I'm going to complicate things for you, Heinz. I'll save you the best pie of the cake. Malperfusion on bypass, how would you deal with that? You shout, somebody screams in the back of your, and it says, oh, you got a malperfusion on bypass.
For example, if you're doing the axillary cannulation, and there's all of a sudden a drop in blood pressure, we immediately do the central cannulation, for example. So, and if we have a primary dissection of the truncus and the left carotid, we do the central cannulation. We do it a little bit differently than you are doing with the Seldinger technique. We are doing an exsanguination, and once the blood is...
Samurai? Do the samurai technique?
I don't know, no. So once the blood pressure drops below 30, we are cutting the aorta, putting in a couple of retractors and do a distal stab, and then we bring in the cannula, de-air, and start perfusion of the true lumen. So this takes 90 seconds, the patient is over-oxygenated. This is, in our hands, the perfect solution for this.
All right, Ali.
Well, I want to also mention that it's also iatrogenic malperfusion that can happen. In fact, with femoral perfusion, there's significantly higher incidence of malperfusion because it's thought to change the initial anatomy of proximal perfusion to the distal, and it can change and vary the hemodynamics and pressurization of false and true lumen different spectrum or within the abdomen. So that's an area that I think femoral cannulation is getting less and less in favor of the majority of cardiac surgeons. The second thing is the transcranial Doppler is one of the reasons I adopted is actually for that malperfusion. Hazem Safi looked at a paper for type A dissections, and about a third of those patients, after going on pump, there were a significant drop of flows to one of the brain vessels. And based upon that, he actually changed the cannulation style, meaning either you had to put a cannula inside the orifices, or he changed basically from groin to the centrally. So I think those things have to be kept in mind because there is an aspect of iatrogenic malperfusion when you go on pump.
All right,
I think the most important thing about malperfusion is that for the first time over the last few years, we actually have a reasonable solution. And I actually believe that a frozen elephant trunk is going to be a class 1A indication for type A dissection repair if you have a significant malperfusion. It's the best indication for a frozen elephant trunk, as far as I can see.
All right. Any comments on that, Ali?
I'll comment. So, I mean, if you look at the malperfusions of descending thoracic aorta, about 90 of them are, as you know very well, as described, is not anatomic. The ones that are anatomic is the one where you have basically a piece of clot or piece of septum within the orifices. So we know in those patients, just stent grafting of the proximal descending thoracic aorta as frozen elephant trunk will not relieve the thing. So I would caution that would fix all the malperfusions.
Yeah, that's not a malperfusion. That's an occlusion of the vessel. Okay, thrombosis of the vessel.
It's called anatomic malperfusion.
There's a difference between a malperfusion and a thrombosis of the vessel. If you have a thrombosis of the vessel, you have to do a surgical bailout. So.
I think there's a difference between dynamic and anatomic malperfusion.
It's also important to make a very early angiography after the operation, after accomplishment of the operation, because not always the frozen elephant trunk solves everything, and maybe some additional interventional radiological techniques, stenting, are necessary to restore perfusion of the superior mesenteric artery. So, but then it's too late if you have a real complete.
So do you routinely do your dissection repairs in a hybrid room?
Now, this is a question I hand over to Heinz.
Well, it's a good question.
Of course. We have this program for the last 12 years, that the patient with acute aortic syndrome comes in, the hybrid room, and the cardiac surgeon, the cardiologist, and the anesthetist is awaiting the patient. So if it was a wrong diagnosis, no problem, patient gets out. But then we have TEE for first thing, and if there is suspicion of type A, okay, instrumentation, and then our cardiologists are doing angiography, because sometimes the CT scans are several hours old. They don't come in like in Japan within an hour. We have 8 hours or 15 hours delay, so maybe the situation is completely different. And I think we have to consider the level of malperfusion. For example, the worst group in our place is the coronary malperfusion.
Yeah.
And then there's no time to lose. You go in and do it very quickly. And the second problem is the visceral malperfusion. And if it's 6 hours or longer, full malperfusion, I don't start operation because we lost all those patients. So we do the stenting first, do the reperfusion of the viscera, and wait with a drainage in the pericardium.
Yeah.
So as long as the patient stays hemodynamically stable, we wait 24 hours or so on the ICU and then go in.
And you have good results with that.
What does it mean, good results? I mean, in my experience with this devastating situation, I had 100% mortality. Now I'm maybe around 30 or so. This is not good, but it's better than it used to be.
Let's wrap it up with one last question to you all. Well, I'll ask Thor actually to wrap it up for us. The best outcome for a patient with aortic dissection is to get them alive out of theater. How to do that? Open repair, supracoronary anastomosis, get the patient out, deal with the other problem later, or do extensively a hemi-arch. Just as a sum up of all this.
Well, I guess the best way to answer that is to quote the great American philosopher Dirty Harry.
That's why I asked you the question.
Dirty Harry Callahan, and he said, who famously said, "A man, and we can take it in this day and age, and a woman, has to know their limitations." So if the best operation in your hands is a supracoronary tube graft, then do a supracoronary tube graft. If it's the balance of what the patient needs, what you can do safely in your environment. And remember, too, it's not just you as the surgeon. How are your perfusionists with circulatory arrest?
Yeah.
I mean, we've got, there are, in the United States at least, there are centers that do 75 pumps a year, 100 pumps a year. Their perfusionists are probably not going to be comfortable with circulatory arrest, and they may be better with a 2-inch tube graft and a cross clamp if they survive. So a man's got to know his limitations.
Great. Good way of ending up this beautiful session, which I'm sure you all agree with. We need to ask more questions, but in the interest of finishing this session, in interest of time, I'm sure you've all had a very laborious day here at EACTS. I'm going to finish this session, and thank you all for coming down, and giving your expert opinion on that. Thank you very much for joining us. You've been with Mo Bashir for the CTSNet Aortic Portal. Thank you.
Thank you.